the person to the very right here, Bo Håkansson, he's part of our team here at Chalmers. He started as a PhD student 1977, and his mission was to develop the first bone-anchored hearing aid. And that was in collaboration also with Per-Ingvar Brånemark, with Brånemark Oslo Integration Center, and with Sahlgrenska University Hospital. And the person from there is Anders Källström, he's a medical doctor. And these are basically called father of osseointegration, the father of bone conduction surgery, and father of bone conduction devices from the different areas of expertise. So I just wanted to show you this first, so you know in which context we are. So today I will talk to you a bit about what bone conduction hearing physiology is, what is bone conduction, about different types of hearing devices within bone conduction, and specifically the project we've had for several years now, a bone conduction implant. Some challenges for implantable bone conduction devices, show a little bit from our preclinical studies and our clinical study, and then summary in the end. I hope that's fine. So, you know about hearing physiology, right? That your sound enters the ear canal, it hits the eardrum, goes into the middle ear with the three ossicles, malleus, incus, and stapes, and then into the inner ear with the cochlea, which is the shell-like structure here, which has a basilar membrane with hair cells on it, and it's a cochlear fluid there, and when the fluid moves, the hair cells are moving and giving an electrical stimuli to further on to the auditory nerve and then to the brain and hearing perception. And that is totally true. That's one part of your hearing. It's called the air conduction part. But we also have bone conduction, which is when vibrations are transmitted throughout the skull bone, and it kind of shakes the inner ear, and it makes it compress and expand. And when that happens, the cochlear fluid is moving, and then the hair cells are moving and giving electrical stimuli to the brain. So you hear in the same way from bone conduction as air conduction from the cochlear node. And that's actually a pretty big part of your hearing, and specifically from your own voice. So when you listen to yourself, there will be sound exiting your mouth and entering the ear canals. So you hear yourself via air conduction, but there are also vibrations transmitted directly from your mouth and your vocal cords throughout the skull bone and to the cochlea. And that's about half of what you hear from your own voice, the bone conduction. So it's an important part. And you can actually feel these vibrations a bit. If you just put your head, please do it. Put your hand above your head, and you say, ooh. Nice. Nice try. So could you feel a bit of vibrations? Yeah. I think this sound ooh when you kind of close your mouth, that is more bone conduction from that one. But if you say e or e, you open your mouth a bit more, and then it's more air conduction. But you can try it for yourself later with different sounds. And also, you know, when you record your own voice and you listen to it, maybe you've noticed you don't sound the same as you hear yourself in real time. And that is because you don't record the bone conduction part. You only record what comes out of your mouth. And that's actually how other people hear you. But you hear yourself in real time with bone conduction as well. Yeah. Okay, you hear bone conduction from surrounding sounds as well, but not as much. It depends on the volume. So if the vibrations in the air will induce vibrations in the skull bone, and you will hear that. So if it's very noisy, you hear a lot via bone conduction as well, but not when just listening to one person talking. And of course, you can hear bone conduction from a vibrating transducer. In this case, it's implanted. It doesn't have to be. You can just press it against the skin somewhere. And then vibrations are transmitted through the skin into the bone. Yeah. But go over to hearing aids. This is very general. There are many different types of hearing devices. The one that is most common is the air conduction device, which just amplifies the sound into the ear canal. And there are other that can bypass an impairment, like the bone conduction devices are doing, and I will get back to that. Or you can stimulate the nerves. And for that, we have the cochlear implants with electrodes into the cochlea, or the auditory brain stem implant, where you actually put electrodes directly onto the brainstem. Not that common, but there it exists. Okay, so bone conduction devices, they are specifically for patients who have conductive or mixed hearing loss. Conductive hearing loss is if you have a problem in the outer or middle ear. So you have a problem conducting the sound to the inner ear. Mixed hearing loss is when you have both conductive and a sensorineural loss. Sensorineural loss is if you have a problem in the inner ear or the auditory nerve. But that must function to some extent for the bone conduction device to work, because it's kind of aiming for the cochlea. So it provides vibrations that bypass the middle ear. If you have problem on both sides, you can use bilateral implants. And if you are deaf on one side, you have single-sided deafness, you can use a device on the deaf side, because the vibrations are not only transmitted to the ipsilateral cochlea, but throughout the skull bone, so they also reach the contralateral cochlea on the other side. So with this healthy cochlea, you hear from both sides, air conduction-wise from the healthy side and bone conduction-wise from the deaf side. So that's a good solution for those patients. I thought I'd give you a bit of historical review of bone conduction devices. So before Bo Håkansson started with the BAHA project, they had these conventional bone conduction devices that you just pressed against the skull bone or against the skin behind the ear, and you attached it often with a steel spring headband or on eyeglasses and the spectacles. But the problem with that was that it needed a high pressure on the skin, because the vibrations are attenuated through the skin. And to get as good sound quality as possible, it pressed it hard. And that gives problem for blood circulation and also pain. And another problem with these was that they needed to have the microphone on the other side of the head, because otherwise it would be feedback problems. You know, feedback problems with hearing aids is often if you heard someone turn on their hearing aid and it's a beeping sound, that's because the sound is bounced from the loudspeaker to the other hand to the microphone, and that's what we call feedback in hearing aids. So if they were to keep microphone on the same side, it would be beeping all the time for this device. So that was that good. So there were a lot of things that could be gained from using another principle instead. So to stimulate directly into the bone, and that could be accomplished by inserting an implant here, a screw, with an abutment and then the device. And though he developed this also so that he could keep the microphone and the transducer in the same casing. So with the suspension in a certain way here. So you have a microphone, you have a battery, of course, and the DSP is digital sound processor. So the amplification is there. From the start, it was analog, but now it's digital. But could you imagine that there are any problems with this BAHA device? Any complications that you could think about? Sorry? Infections, yeah. Because we have this skin penetration here, and you need to take care of that area every day. Otherwise, you will get infections. But you could get infections anyway. And also, the implant might fall off either because of trauma, it's hit, or spontaneous also. And some people reject this device because they don't want the screw sticking out of their head. So that triggered the development of implantable bone conduction devices, where the skin could be kept intact. Yeah, now there are so many different devices, so we needed to make some kind of classification of them. And the first division is between direct drive and skin drive devices. So direct drive is if you stimulate directly into the bone, and skin drive is if it's via the skin. And the conventional ones we can find here, non-invasive, on the skin drive side. Now they are much more developed than the one that was before the BAHA. You can find the BAHA over here is the percutaneous one through the skin. And then we have the implantable, a type of implantable ones with the skin intact. So this is with implanted magnet, and this with implanted transducer. So again, the percutaneous bone conduction device, the BAHA, uses direct bone conduction. It's known as the golden standard in this area still. There are more than 300,000 patients documented at least. I think there are more than 400,000 now, but I haven't got a reference for that. So it's been around for 48 years now. So they had, Bohukan started to develop it in 1977, and they had surgeries the same year. It was a bit different at that time. So 48 years. There are 2 companies in the world that develop this type of device, and both are in the Gothenburg region. And it's Cochlear Bone Anchored Solution. Out in Mölnlycke, if you go to the airport, you will pass it on the highway. It's a big glass building. And then it's Orticon Medical and in Askim, Siegen, in the southern part of Gothenburg. So Cochlear has the BAHA system and Orticon Medical has the Ponto system, and they are available in different power classes depending on the sensorineural part of the hearing loss for the patient. Okay, and then we have many transcutaneous devices then. I mentioned both direct bone conduction and skin drive. And for the skin drive, vibrations are attenuated through the skin. And we should know that too high pressure will lead to complications. For the direct bone conduction, we have transmission over the skin via an induction link. So the vibrations are then transmitted directly into the bone. Some pictures of each type here. Here are the non-invasive these days. I think the most common one is to use a soft band. So it's an elastic headband that you put around your head, and you attach the device on the button there. Then we have adhesive fixation as well with plaster, and the sound arc, which is a headband that you have a bit stiffer behind your neck. So these are used mainly for small children, and as a demo before having a surgery, because we want to know that bone conduction device works for this patient before actually doing the surgery. Then we have the passive transcutaneous devices with the implanted magnet, and just so you have a magnet or two inside of the skin, and then you put the external transducer on top outside. So the only advantage against these non-invasive ones is that you don't need an extra device. You can just put it on with the magnet. I think these are on the way out. I haven't seen any publications from a Sopono for some years. So I think the future is among the active transcutaneous devices. So here we have Bone Bridge from Medel, we have Ossia from Cochlear. This is the BCI that we have in our Chalmers project, and Sentio from Nautica Medical, which is based on our BCI from a collaboration. Just wanted to show you a bit that it takes a long time with the development of these medical devices. Bo Håkansson, he got the idea 1998, but shouldn't we have an implantable device with intact skin and implanted speaker and stimulation close to the cochlea? And he started to present that idea at conferences, and no one really believed him. No, that's not going to happen. But he started to work on it for himself. And he started by developing a smaller transducer that would fit in the temporal bone. And that he published 2003. It's called a balanced electromagnetic separation transducer, or short, BEST transducer. It's really best. It's small, and it has it gives low distortion and is quite efficient. So it's much better than the one that was in the BAHA previously. So, and this triggered also many preclinical studies to proceed in this development. Just wanted to show you also a bit how the principle for the BCI. We have an external audio processor and an internal bridging bone conductor, or just call it the implant. I wanted to bring it to show you, but then I didn't find it, and I phoned Bo, and he said, "Oh, I have it at home." So I'm sorry, I will just show you pictures today. But this is what it looks like. So you have an implant here and the external audio processor here, attached with a retention magnet. So in the audio processor, you have a microphone, you have a digital signal processor, the batteries, of course, on the outside. You never need to change any batteries in the implant. Some modulation is used, and then it's amplitude modulation, an inductive link then over the skin, and you need a demodulator on the inside, and then to the BEST transducer to give vibrations here. So there are plenty of challenges when you're developing implantable devices, and then that will lead to many preclinical studies. So what are the challenges? Could you just talk 2 and 2 or 3 and 3 and see if you come up with any challenges? Let me know. So please. Yeah. We start with the online. But it's definitely no, to get it into the body, more or less. Yeah, but you need to, yeah, you need to think about what is needed to get it up to the market in the end. But
just to get started with
right,
just getting started with my basic.
okay, that's it. Okay, do you have any suggestions? Any ideas? Right?
Finding patients, finding material.
Finding patients and finding materials, yeah, absolutely. That's good.
Getting ethical approval.
Yeah, technical approval. That's a huge thing. Yeah. And what you need before that. And to get, if you finally want to get it into patients, what is needed before?
And it's electrical device. We need to really have lots of standard electrical slates, all of this.
Yeah, there's a lot of standards. Yeah, good.
That the materials are biocompatible.
Biocompatible, yeah, good. Very good. Yeah, sorry,
The stress on the scalp.
stress on the scalp, yeah, good.
So it could be like a difference, a pressure differential. The inside of the camera.
Sorry, I can't hear right now. Just a second.
Will be like pressure differentials inside the cavity outside, so it's like input from the scalp.
I'm not sure I understood completely. No, please.
No, I'll explain more. So when you're doing intervention, you need to make a call. So there's a huge pressure difference between the inside of the skull and the outside.
You mean when?
To reflect on inflammation.
You mean during the surgery when you drill this recess for it? Yeah.
I just didn't
So yeah, so you need to put a small static pressure on it. Was that the one? I will get to that. We'll put a small static pressure on it when it's in the recess. Yeah.
Maybe the point is you have to prove that it's safe to do this.
Yeah.
But you have to prove that it's safe before you do it somehow.
Somehow, yes,
Right.
exactly. You need to prove that it's safe. That's how. Yeah. That's the thing. Yeah.
What about the challenges of the improvement of electronics along this time? So when you have the implant, maybe the new device system might have better.
Yeah, there will be devices after some years and better technology, and we want to aim for having the implant as long as possible, but it will work for a very long time because you don't want to keep doing surgery and change it. So long lifetime. Yeah. Good. Anything more?
Yes, aesthetics. People probably would prefer discrete design.
Discrete design, absolutely. Yeah. Good.
Removal, if the patient decides not to remove it.
Removal, yeah. That should also be easy to make. Yeah. Good. So you have many good suggestions. I haven't all of them in my list, but I have some that I thought I could talk about here. But the rest of what you said is also good. We need to know that it's powerful enough. We don't want to put in something that is less efficient than previous devices, because then it won't be used. It should be small enough. We mentioned that we'll develop a smaller transducer to fit into the temporal bone. We need to have a good attachment to a bone in the body. We'll need to look at the MRI compatibility, and that it's effective and safe for patients.
MRI, magnetic resonance imaging.
Yeah. Sorry, magnetic resonance.
Why is that needed?
That is examination that is quite much used, and more and more used, I should say. So
In particular, in these patients.
no,
Just
but in
general.
in general. Mhm.
It's latent. Is that possible? It's metal.
Exactly. It's a problem, and we have magnets in there, and things could happen. I will show you a little bit about that. Yeah. So, yeah, I just want to show you this picture because it has, it shows a lot of different preclinical studies. But basically, I want to just say that we had many different and sort of environments where we measured different things. We have used a damp dry skull, a real skull. We have used cadaver heads to measure. We have used animal study of sheep. We have used normal hearing subjects. So the skull simulator, it's something that Bo needed to develop in the 80s when he did his PhD project to measure the BAHA and it simulates the impedance of the skull, of a skull bone. So we could of course use that for BCI as well. So there are several different environments. I'll get back to some of them. So one thing is that the device should be powerful enough. And how do we measure that? Well, we know what comes out of the device, and that is called maximum power output, the maximum power that the device can give. So that is what limiting the output force. Now we are having an induction link, and that will reduce the MPO by approximately 10 decibels. So we need to gain that back in some way. And our hypothesis was that it will be increased if we move a transducer closer to the cochlea as compared to where the BAHA sits. So I don't know if this picture is too small now, but here you can see position A as where the BAHA is normally placed, and position B where we have the BCI. So A is it's a line from the from the eye on top of the ear, and then it should also be 55 millimeters from the ear canal. So it's this here where that and those measures meet. And the BCI is placed a bit closer than, as close as possible when we pull back the pinna like this. So this is made on normal hearing subjects. We've also done the same thing with BAHA patients where the middle ear is actually open, so we could measure with a laser Doppler vibrometer on the cochlear promontory. But here, for normal hearing subjects, we measured the thresholds, the hearing thresholds. And we measured also the ear canal sound pressure. So we put in a sound probe through an ear plug and placed it as close to the eardrum as possible. And then we attached the microphone on the outside. So we did that when simulating both on position A and B. And we can see the differences here, B versus A. So if it's more than 0, it means that we have a benefit for position B. So we can see that we have a benefit of about 5 to 10 decibels, depending on frequency. And we could also see that these measures are approximately the same in relative measures. And then we have also one other thing about the best transducer. It gives a high frequency boost around 45 kilohertz. That was not possible with the regular BAHA transducer. And together, we could see that in total, we should have the same MPO as for the BAHA. So that was good. So it should be powerful enough. Then small enough. Yeah, so developed this small transducer, and that was good, but we wanted to also check in normal temporal bones, how would it fit? So we had CT images that we packed into 3D structures. And then we inserted a virtual implant that we could change in radius and in depth. So we checked how big can it be. If you have a certain depth, how big can the radius be, and then changed it. And then we get all these curves here. These are the temporal bones. And if we just mirror it and insert our BCI transducer in the worst possible position, we need a little bit of a part of it to protrude the bony surface here to get the static pressure. We see that it doesn't hit any of these curves, meaning that it would fit all of these temporal bones in this study. Then we tried also to insert the bone bridge, which is much larger, and that only fits 40% of these temporal bones. And that's their problem. They are so big. They have screws here and here that need to be attached into the bone. But because they didn't fit all of the temporal bones that they needed to, they needed to arrange that in some way. So they produced a lifter so that this could be put further outside, and it's a plastic piece here. So it's protruding the bone surface much more, and then it's much visible on the outside as well of the skin. So that's their disadvantage. But the BCI worked, at least. Then we talked about bone, good attachment to the bone, and that is also about biocompatibility and osseointegration. We wanted to see that we could use a flat surface instead of screw, because we know that screws are working from the BAHA, but we want the flat surface. So we did that in 3G and checked the transmission properties and also histology. So what we came up with is that flat surface would be equally good as using a screw, and we produce a small static pressure with a titanium wire. The problem with this sheep study was that they used this, or they had this dummy implant for 8 months, but they tend to scratch very much. So some of them were loose after this time as well. But the results are from what we could see, from what was left of them at least. So that was a problem with the sheep. I will show you a few surgery images. If you have a problem with blood, you should just look away, okay? So in the surgery, I may draw a picture of where the implant should be placed and a line for the incision. And then I open up with the incision and drill a recess for the implant here. And then the implant is ready to insert it, and the antenna part is just pressed in underneath the skin, and the transducer is given a small static pressure with a titanium wire. I don't know if you see it here, but that's what the surgeon is holding. But we have one issue here, and that is, does the implant work after this surgery? When you close the wound, you need to know that this is working implant, because we have measured it before and it's working. But then it goes through sterilization and handling during surgery. So we need to figure it out if it works. And then we know that if we have an external audio processor that we can give, it's a custom-made one that we can give a signal. And we know that if the induction link works and if the implant works as it should be transmitting vibrations that are transmitted throughout the skull bone. And if we are actually just close enough and listening, we could hear that. But we really want to measure it as well in an objective way. And then we thought maybe we could use the ear canal sound pressure that we have a lot of. Experience of using that. And then, as you saw in this photo here, the pinna is folded on top of the ear canal, and it's a sterile area, so we cannot put our measurement equipment there. But the transmissions, they are radiated into all cavities of a skull bone. Into sinuses, into ear canals, but also into the nostrils. So we're actually using nasal sound pressure for this. It sounds a bit weird, but it works very good. So we measured in the nostril for all the patients to know that the implant was working. So we did that both at the surgery and then all follow-up visits that we had in the clinical study. These are the details. What we could see is that these are curves for all the follow-up visits, and they are almost exactly the same. This is for one patient. The blue curve you see here is for surgery, and that was a bit different because then you're laying down and anesthetized, while in the follow-up visits, you sit up and hold your breath for a while the measurement is done. So it was almost like a fingerprint for the patient. And if you look at the averages for follow-up measurements for all the patients, you see the variety in their responses. So after a while using or analyzing the data and everything, I could almost identify the patient from just looking at the curves. So we saw that we get a large variability between patients, but low inter-subject variability. And we could use this to verify the functionality of the implant. And this we used also, we used it in follow-up visits, but also almost 2 years ago, we had one of the patients who had used his implant for over 9 years, 9.3 years, and he came back and it didn't work. And it was not the audio processor that needed to fix. So we measured and wanted to see if it worked, and then it was nothing. So it's really visible that it's really good measure of it. But then it's not really clinically accepted to put something up your nose when you come into the clinic as a patient. Now we have better equipment, but we didn't have that at the time. But we have a skin microphone that we could put on the forehead instead. That's much simpler. But we didn't have that at the time. Yeah. Oh, what about the time?
I think it's interesting.
Thank you. So we talked about the MRI compatibility, or just mentioned it. And that's a huge problem for many implants. If you have metals or magnets inside of a body, it will create a large what is it called? Artifacts. Yes, that was my word. Thank you. So it's a large artifact. You see the one without an implant and with an implant here. And this is measured for one volunteer subject who is not using the BCI. He's not a patient in this study, someone else, putting the BCI implant on the outside and attaching with all of these bandages. So it's really stuck there. So what we were worried about also was the functionality of the implant after an MRI. And we could have, we have a retention magnet inside, and that could get less efficient. And also the transducer has magnets inside of it, metals, and that could lose its functionality. But now we could see that it did happen, but not that much. So it worked just fine afterwards also. So if it would be needed, the patients could use an MRI. But we thought it would be likely to pass an approval for MR conditional at 1.5 Tesla, which means that you need to do something before doing the MRI. For example, use a compression band. So. Then the BCI was approved for a clinical study. It's very much examined here by our medical doctor at Sahlgrenska, Måns Erik Olofsson. So we had the first patient surgery in 2012. And we had 13 patients at Sahlgrenska here in Gothenburg and 3 in Stockholm at Karolinska. Yeah, so we had some research questions, not only these, but is it safe and is it effective? And we thought it was safe already before, but we also wanted to see it in the clinical study. This is too much information, but we have in the clinical study, we have a time plan for each patient, which is up to 5 years. So we first get to use Ponto Pro Power, which is a BAHA on a soft band for 4 weeks, and then doing measurements. And after that, we had surgery for the BCI and fitting of the audio processor. And then we had many tests, many follow-up measurements, up to 5 years after fitting. Yeah. So these are the 1-year results. We have many more, but just wanted to show you a little bit. These are the threshold improvement from unaided to using the device. You can see the difference between the blue BCI and the red reference. But now we're comparing to a device on the skin, and we know that that would be less effective, and we can also see it here. But the sound quality isn't as good with the reference device, and it's mainly on the high frequencies. So we wanted to compare also with the percutaneous implant, and we cannot do this in the same patients, but we could find matched BAHA patients, so patients with the same age, gender, and hearing loss for each patient, and then we could do the same measurements on them and questionnaires and compare. And then we see these curves instead, and it looks like it's almost, not exactly, but almost the same as with the BAHA in basically every test that we did. We had some questionnaires checking the quality of life and what they think about the sound quality, and that was in favor for the BCI, and probably because the BAHA patients have had their implant for longer time, and some of them had some complications, infections, and so on. And the BCI patient didn't. So it looks good that way. Yes, they're just two of our happy patients. The patients have had their implants now for between 8 and 12 years. And during this time, we had no serious adverse events. We had, as I told you, one explantation, and then we could also see that it was easy to remove it also. When removing this titanium wire, we could just lift it basically, or the surgeon. Yeah. And this patient got a bone bridge instead, because at that time we didn't have a CE-marked implant still. Many publications around the clinical study. In the last one, I have this QR code here. We also describe all of the preclinical studies that were made, in case you're interested in it. The summary of the clinical study is that BCI is safe and effective for patients. We had similar audiological results as the BAHA, which is the golden standard, intact skin and less feedback also compared to the BAHA. I didn't talk about that, but that is also correct. But when you use the BAHA, you can actually not use a soft hat in the winter because it's too much feedback. But with the BCI, the microphone and the transducer are further away from each other, so then it's not as much feedback. So it's very good. And no serious adverse events. I mentioned that we had collaboration with Ultron Medical, a company, and they have now launched a Sentio system, which is based on the BCI concept. And their audio processor is compatible with the BCI implant. So now our patients have received their audio processor, which had more functionality than ours had. And it was CE marked and FDA approved last summer. So that's good. Okay. A little bit of summary, what we talked about today. We talked about bone conduction and air conduction. We learned what that is. A bit about bone conduction hearing physiology. Different types of bone conduction devices. We have direct drive and skin drive. And we talked about challenges for implantable bone conduction devices. And a bit of preclinical and clinical studies. So Bo had this idea in 1998, and 2024 it's launched on the market. That's 26 years for this medical device, from idea to market. 14 years until we started the clinical study. That's a lot of time. It takes time nowadays. It was much faster with the BAHA in those days. But yeah, it's worth it when you see the the happy patients, and I've met all of them, and when you put on the device for the first time, it's wow, what I'm hearing. So that's very rewarding, I think. So thank you very much for listening. These are some of my closest collaborators within the BCI project right now. Thank you.